right. Well, it is 6:30, and I want to thank everyone for joining us for our kind of fourth iteration of the military medical community. Tonight, I'm really excited. We've got three great speakers talking about the unconventional internist. You're not, as an internal med doc in the military, you're not just sitting down in the same clinic, seeing 25 patients a day, prescribing the same 12 medications. Today, I'm really excited to hear from these three speakers that will show you how you can leverage your internal medicine skills in so many different locations, clinic settings, disaster scenarios, and really just kind of work outside. Of course, Dr. O'Sullivan with the rheumatology drop. I will not introduce each speaker and give them their spiel because I'll allow them to do it. But these are three really exciting speakers with very diverse career paths, and we'll dive in. But a few things. A big thanks. Dr. Renee Mallory and Dr. Hemmer are on the call tonight, and they'll be in a couple of the breakout rooms, working with the American College of Physicians, as well as our Army, Navy, and Air Force HPSP physician recruiters. So if you're looking at military medicine, again from USU, we always want to make sure that people are interested in military medicine. So if you're in the application cycle and looking at USU, I highly encourage you to also be talking to an HPSP recruiter. And this is your opportunity in the breakout rooms to speak with an Army, Navy, Air Force physician recruiter. And again, a big throwdown. If you enjoy all the stories that you're hearing tonight and just kind of seeing, Dr. McCarthy, the GI doc with his kid in his lap, and hearing these stories and seeing what a life in the military medicine looks like. You can also tie into War Docs, and they have their own web-based program where you can listen to story after story of some really cool docs that have done a lot of cool things. I always like to say I've done and seen things most docs never read about. And then again, whether you're in med school or you're a current undergraduate student and you're interested in starting your own military medical community at your local institution, you can pop onto the website and download the bylaws, set everything up. We're happy to help you do that. If you are in those application cycles, either for residency or for medical school, this is another opportunity for you to put some leadership down, which are one of those pre-med competencies. So, and with that, I'm super excited to present one of my research mentors, Dr. Day, who's an allergy immunology doc down in Portsmouth. And I'll let you take over, Grant, but he's going to highlight the diverse research opportunities that he's leveraged within his military time. So thanks, Dr. Day, for joining us tonight.
Well, thanks for having me, Dr. Cox. I think research mentor is a bit of a stretch, but I'll take what I can get, I guess. But hi, Grant Day. It's nice to meet all of you, and thank you to Dr. Cox and for all of you for the opportunity to speak today. A little bit of some background for me. I'll give you kind of my loop here. So I went to college at Virginia Commonwealth University. Go Rams! They did pretty well in the recent Bahamas basketball tournament. So then from there, graduated with a biochemistry degree, and then went to what used to be called Eastern Virginia Medical School for my MD degree. They recently changed to a much longer name. From there, I commissioned HPSP, and then commissioned and went to Naval Medical Center Portsmouth for internal medicine. So I did my intern year and then residency training there. And as well as I did a chief resident year too, so I have some experience from that perspective. And then from there, went to Walter Reed and did my allergy immunology fellowship. Oh yeah, see, go Rams! Went to nursing school. So did my wife. Yeah, that's great. That's where I'm at. VCU is the best. And went to Walter Reed for allergy immunology fellowship, and that's where I met Dr. Cox, and we had a great relationship from a research and clinical setting. And then recently from there, came back to Naval Medical Center Portsmouth, and now the division head for allergy immunology there at Portsmouth. So far in the Navy, I've really gotten to see the world. But a lot of great opportunities for research that I'll get into. So briefly wanted to kind of pull a small plug in for why allergy immunology, and why it kind of fits my interest in internal medicine in general. I think during residency, I was really drawn to diseases that bridge, complex diseases that bridge multi-systems that were involved infection, involved cancer, involved autoimmunity, or a combination therein. And I felt like I was drawn to the immune system because I felt like it tied in all those systems together and really permeated a lot of different aspects of disease and medical therapies and treatments. I also loved the clinical detective work, which I think is one of a big piece of what draws folks to internal medicine is, that initial phase is the diagnostician, having a patient come in through the ER or come in from an outside facility and having to figure out what's going on and how to best help them. And I think that detective work really extends to the allergy immunology field. There's a lot of, questioning as to what's going on, what is the immune system doing here, and how can we help? And I think allergy immunology in particular has a good combination of acute problem solving, but also long-term relationships with patients. And I think that also extends generally to the internist, following patients through the course of their life, the course of their various diseases, and also preventative strategies to help them. And then finally, as I had mentioned and kind of reiterating, it's a systems thinking specialty, so it touches every organ system and connects to precision medicine, which I think is an ever progressing field. And then finally, which is what I'll kind of the crux of my brief presentation is, I feel like allergy immunology, because of that precision medicine, is a gateway to research, translational medicine, as we're progressing more towards targeted treatments and therapies. Dr. Cox also asked me to do a couple of slides on, I think, what makes a great rotator through internal medicine and just, I guess, rotations in general. And I felt like there was I had mentors of mine, Dr. Michael Dorr, if anyone knows him. He gave me these 4 main keys to excellence on rotations, and I'm shamelessly stealing them from him. But the first one is to be reliable. And I think that's, of course, the number one, showing up on time. And I think a part of that is getting clear expectations on the rotation from day one. What do you expect of me in terms of notes, in terms of, patient interactions, number of patients, et cetera. And I think setting that clear expectations and then meeting those objectives and being reliable is paramount to success. Be interested. I don't think this necessarily means, feigning any interest, but I found that, especially if you're here and you're interested in internal medicine, you're interested in a broad spectrum of diseases. And I think that you can find something that you're passionate about to read about, really from any rotation. And I think that really permeates. And, as a staff that's had medical students and things, that really shines through when you gauge an interest and you show that you've read on the outside, at least something that you found that you can latch onto. And then be coachable. I think that's another big one. And that's something that, Dr. Dorr told me is like, you take feedback and you be able to immediately apply it for the next round and kind of progress through that process. And that's how we learn. And I think being coachable is very important. And then, of course, being useful. So I think for this is, finding things that are, and anticipating things that need to happen. Hey, that person needs to get the CT, or, this lab wasn't put in, those kind of things. Taking ownership of your patient and anticipating those things, especially, from my prior experience on the inpatient wards. I mean, that's, it's complex. There's a lot going on, and being that person who's the advocate for the patient and anticipating those things can be very helpful. And I think taking it to the next level is how to stand out. And I think for those, the first would be what's termed pick a micro project and take ownership. A lot of times you're on a rotation for 4 weeks, 8 weeks. For in allergy immunology, I get a med student, 1 day a week for a month. So with that, you have to have what's considered a SMART goal, so specific, measurable, attainable, realistic, and timely, and being able to pick those things out, like creating a cheat sheet for other med students to go through, finding resources and collating them together. Just small things, either on the rotation or outside of that, can be really useful, and I think it shows that you're taking that next step. Building a feedback loop was one that, again, Dr. Dorr, shamelessly stealing, taught me was, setting those clear expectations for feedback in the beginning, but then having benchmarks throughout your rotation to say, hey, what can I be doing better? How can I improve? Of course, not, getting to the point where you're asking every, 5 minutes, but, having benchmarks that you're showing that you want to improve, I think, in developing that loop can be helpful. And then finally, of course, tying back in research, one great case can really take you from a scholarship standpoint, whether it be from, a case presentation at the ACP conference to an oral presentation to a manuscript. And I really think that, kind of wringing the towel of all the things you can take from a case, one can, kind of teach you that process of research, but also can help you stand out by taking, something that you learned clinically and teaching others about it through research and academia. So kind of the crux of what I was here to talk about was examples of research possible, and kind of just some things that I've been working on over the past couple of years, a lot of which with Dr. Cox, that we can kind of share just the breadth of what's possible through military medicine. Because I think, military medicine, a lot of times from an outside perspective looking in, you think of hard charging, prolonged field care out in the, and all that stuff is incredibly important in first line, and that's great. But I also think people skip on the fact that there's a lot of research in the background, whether it be from trauma or internal medicine or what have you, that makes all that stuff possible and more streamlined. And that's a great, unique opportunity for military medicine. So on that thread, kind of the main project that I've been working on over the past couple of years is called Toxin HL, or toxin exposures in active duty service members with B-cell non-Hodgkin's lymphoma. So there's been a lot of talk in recent literature, particularly I'm recalling Air Force missileers having an increased rate of non-Hodgkin's lymphoma in the papers, and of course, like Camp Lejeune having an increased risk of various cancers over the past few years. So that's really spurred on the White House a few years ago to release a Cancer Moonshot 2.0, where they're calling for researchers to help close that gap and figure out, why are these active duty service members getting various cancers more than the general population, and is there a particular toxin that we can use in a preventative strategy that we can use to prevent our active duty service members from getting cancer and get it back in the fight. So what we did was we developed a multi-omics natural history study. And what we're doing is we're leveraging the Uniformed Services University. They have the American Genome Center that can do whole genome sequencing, which is a very powerful tool to learn about all the genetic changes that are going on in various patients with cancer, to figure out, are there any genetic changes that are predisposing them to lymphoma. In addition to that, we're getting clinical outcomes data, things like progression-free survival, overall survival, infection risk, hospitalizations, things like that. And we're also getting a comprehensive toxin history, and then that's not only from speaking with the patients and where they've been deployed, but also leveraging some unique tools in the military. One being the individual longitudinal exposure record, which is just a collation of a lot of objective data about incidents and various things that these service members have been exposed to, that we can pull data from and collate that with the other data, as I mentioned. And then finally, I think, near and dear to my heart as an immunologist is the immunophenotyping. So, lymphoma is a cancer of the immune system. We want to figure out what the immune system is doing and what it looks like at various points in time, either before diagnosis, during diagnosis, or even after treatment. And I think that's very important in the context of everything here. In addition to that, we're also getting sequencing not only of the patients and their what we call germline, so the genes that they're born with, but also somatic tumor sequencing, which we can use the Joint Pathology Center and various other means to collect that tumor tissue and compare it to their germline sequence to see if there are any pathway changes that was a toxin contributing to that cancer gene change from their germline. And then finally, using a unique resource in the military called the Department of Defense Serum Repository, which collects serum on active duty service members and stores that, for surveillance strategies and various other public, and health concerns, but can also be leveraged for research. So putting all this stuff together, we can get a very comprehensive picture, which I'd argue is probably one of the more comprehensive pictures for B-cell non-Hodgkin's lymphoma out there. And I think that the military, again, is uniquely poised to be able to have, given all these resources, to collate them together to answer some important questions for lymphoma for service members and also for the general public. So moving on, and now for something completely different, as Monty Python says. So the other cool thing about allergy immunology is we get to deal not only in the immunology sense and immune deficiency, but also in allergy and looking at biologic therapies, which are these monoclonal antibodies that target very specific parts of the immune system that are just coming on the market, faster than we can do research on them. But dupilumab is one in particular that's been on the market for a while that we use for asthma, sinus disease, and atopic dermatitis or eczema. But there's been limited data on how that monoclonal antibody affects pregnancy. And I think I can't highlight enough that we have a very unique resource called the Military Healthcare System Data Repository that links patient data with child data, and we're able to leverage that across a multi-million person healthcare system to be able to answer questions is dupilumab safe in pregnancy? And I think that's important not only for understanding the mechanism of dupilumab and the safety, but also there's a lot of patients that with asthma, for example, that are pregnant that have to go on substandard therapy because we don't have a clear understanding of if dupilumab works. And I think something like this could be to be very helpful. So again, something that's unique to the military that we can use. And then finally, we also can get involved in phase 3 clinical trials. And I think that's another unique thing that other healthcare institutions, and the big quaternary centers and the big name Ivy schools, of course, have that a lot more often. But I think it's missed that the military also has these opportunities. And there's one that I'm a associate investigator on, and Dr. Luke Pittman's the principal investigator on. It's called the Excel trial. So again, going back to non-Hodgkin's lymphoma as well as CLL and multiple myeloma, these are blood cancers that we're using targeted treatments to kill their B cells, which kills the malignant B cell, but also can kill our normal B cells too. And again, as an immunologist, B cells are near and dear to my heart because they make antibodies that help fight infections, right? So we want to see if this treatment called Zimbify, which is replacing antibodies for these patients, will be helpful in preventing infections. So again, all this to say is that the military also has an opportunity to do very big time phase 3 double-blind placebo-controlled trials as well. So just to kind of summarize here, I think making research approachable, that was a lot I threw at you. But I think for you guys is to start small. Again, case reports, going to scholarship. Quality improvement is also an important facet to this. I think, you have so many people tell you to read, but I think reading is important in order to understand where the gaps are in research and in a topic that you're interested in. And then you can help fill that with a case report or what have you to start with. And I think for me, the biggest one is finding good mentors and teams to work with. There's so many great physicians and researchers in the military that are more than happy to want to work with you. And I think, latching on to a good team or the projects you're interested in early on is a way to kind of stand out and set yourself apart. And I think finally, I think the most, if not the most important thing, is do something you're interested in. Don't kind of go down a rabbit hole of something because it's available. Really kind of take stock into, am I interested in reading about this? Because research takes time. So, you want to take up that time with something that you're interested in reading and talking about, because with all the work that you're going to do, you're going to become the subject matter expert. So there's a lot of time with this. So again, Dr. Cox, thank you so much. And thank you everybody for listening to me. This is my email address here. Please jot it down, take a picture, whatever. If you have any questions, feel free to reach out, and thank you so much.
Yeah, pretty amazing. So like our Dupixent study, over 1 million people worldwide are being treated with this medication, and we still don't really have good pregnancy safety data. And so the opportunity within the military system to research that, it's like super cool. So I'm really excited. Thanks for helping us pull that together. Thanks, Dr. Day. All right, we are going to move on. We have Dr. Massey with us. So we're going to totally switch gears from, if you want one path in military medicine, doing research, you've seen a really rich career. If you want to just go live in Italy and hang out, and I'm not even sure what Colin did, Dr. Massey, join us, my friend. Dr. Massey's had a really exciting career, a roundabout path to military medicine, and I'm excited to see how he kind of ties this all together for us. So good friend and wine drinker extraordinaire. Thanks, Dr. Massey, for being here.
Thanks, everyone, for being here tonight. Again, Dr. Cox, USU, military medical community. Thanks again for giving me the opportunity to talk with you all just briefly this evening, hopefully briefly. I'm really excited to have the opportunity to give this talk. This is probably the first time, believe it or not, in the entire past 10 years since graduating from residency that I've kind of had a chance to just reflect on everything over the past decade since my decision to join the Army, the places I've done, things I've done, and then to talk about those. Dr. Cox, got to call you out during the advertisement for this. You called it a hardship tour in northern Italy. My wife and I just laughed at that because probably, the only hard thing about being in northern Italy is deciding whether or not it's pizza or pasta every night. But it's truly been a dream come true getting to be over there. This is going to be a lightning quick run through of my experiences over the past decade as an Army internist. I've been extremely blessed to have the opportunities that I've had. My life and my career probably don't look anything like what folks would think of when they think of a doctor of internal medicine. I think I skipped my disclaimer. No pertinent financial conflicts of interest. Do have to specify that all ideas in this presentation are my own. They do not represent necessarily the U.S. Army, Johns Hopkins, University of Texas. Another disclaimer, there is a hand gesture you'll see frequently associated with the University of Texas. So if there are any folks here from Texas A&M or OU, I apologize if you're triggered by this presentation. So my one-liner, I'm a 39-year-old native Texan. I'm a husband and father of 2. My profession is Doctor of Internal Medicine, currently serving as an active duty U.S. Army internist, Battalion Surgeon in the 173rd Airborne in Vicenza, Italy. As far as how I got here, I'm from Abilene, Texas. Attended University of Texas in Austin for undergrad, medical school, UT Houston. Did all of my training as a civilian at Johns Hopkins Hospital, where I was then a hospitalist for a couple of years before I joined the Army back in 2017. Some fun facts. I was actually in the stands at the 2005 National Championship football game when Texas beat USC. I've been to all 5 of the Normandy D-Day invasion beaches and the bridge across the Rhine in Arnhem, which is known to history as the Bridge Too Far. I finished the Athens Marathon 2 years ago, and my all-time zebra diagnosis, this happened when I was a senior resident, actually came across a case of prion disease, which presumed sporadic. So story thus far, I already kind of talked about what brought me up to the point where I joined the Army, but you guys are going to notice that I did all this stuff as a civilian, and then in 2017 made the decision to commission into the U.S. Army. And I'll talk a little bit more about that decision in a couple of slides. But as you can see from this slide, that really kind of kicked things over into overdrive as far as just like the pace of life. My first assignment once I joined the Army was at Walter Reed National Military Medical Center, where I was an internist and primary care provider in the general internal medicine clinic. During that time, I also was able to do 2 overseas tours, one in South Korea with 3rd Infantry Division, and then another one in Afghanistan with 10th Mountain Division. In 2022, I left Walter Reed and decided to go be a battalion surgeon in the 173rd Airborne in Italy, where I've remained to this day. And at the bottom of the slide here, you can see a couple of the schools and additional training opportunities I've had the opportunity to participate in. EFMB, there's the Expert Field Medical Badge. In 2021, I was actually able to spend most of a summer up at the U.S. Military Academy at West Point with the cadets, where I provided medical coverage for their cadet summer training. And then went to airborne school, flight surgeon school, which I can talk about later. And then most recently, the Jump Master course, which I just finished last month. Briefly talking about residency, I know you guys probably know what an internal medicine residency consists of, so I won't belabor it, but my residency experience was very inpatient focused in Baltimore, ballpark 18 months spent on a general internal medicine ward, and then 3 to 6 months of critical care, and then the rest filled out by electives and primary care clinic. I probably would comment that a decade ago, primary care was not the biggest emphasis in my residency. I do know that a lot of residency programs, Hopkins included, have taken a lot of steps to make that a more immersive experience for their residents. We saw the gambit of internal medicine, adult diseases, and the call schedule was somewhat exhaustive. We did overnight call Q5, and critical care was every third day. And someone actually did take a picture of me falling asleep while standing. Some reflections and kind of some advice that I could give you guys who are all pre-residency. I think it is important to realize that your internal medicine or your residency is likely to be a lifetime formative experience. For me, it certainly does remain the foundation of my entire identity from a professional perspective, and in a lot of ways also a big part of who I am as a person. So it's an important decision where you want to go to complete your residency and what you want to train in. As far as deciding location versus program, you have to do what's right for you and your family. But when deciding on a program, I think it's important that you look for a place that'll challenge you and a place that has significant pathology. I love the city of Baltimore, but I'll say that it is a microcosm of all the societal ills of America. And accordingly, I saw a lot of advanced pathology. Whether or not it was cardiovascular disease, alcohol. It was the epicenter of the opioid epidemic that we're still fighting to this day. As far as the decision of whether or not to do primary care and general internal medicine versus subspecialty medicine, I've got a little bit of a unique vantage on that, in that for most of my training, I thought I was going to go into a medical subspecialty. I actually wanted to be an infectious diseases doctor. It wasn't until about the final 6 months of my residency that I actually tapped the brakes. And it's not that I don't love ID. I really do. A lot of people joke that I like bacteria more than I like people. But I realized that I just like everything else too much. I like getting to do cardiology. I like nephrology, so on and so forth. And I really love the team environment of the inpatient internal medicine wards. That's continued to be some of the most rewarding times I've had throughout my time in the military. From your residency, you will have lifelong friends and colleagues. It was just a couple of months ago that I actually called up a buddy of mine regarding a difficult case that had come up in my hometown, small town Texas, and he was actually able to get her referred and taken care of. And then briefly, I do want to talk about civilian versus military residency, because I do have that vantage of I went from a civilian program into the military, and then pretty quick thereon became an attending physician overseeing the residents at Walter Reed. And, I'm proud to say the guys at Walter Reed, they are bar none some of the best physicians in the country, and they absolutely provide first-rate care and extremely complicated cases in our retirees and dependents that they take care of day in and day out. Going to my next slide. So, just briefly on this slide, just kind of want to reflect on the fact that it's been a decade since I finished residency, but medicine has absolutely moved at a breakneck pace in how it's evolved, some for the better, some for the worst. Y'all can see some things here on this slide that I'm glad have gone by the wayside. Thank goodness we're not prescribing warfarin to many folks anymore, and we're not giving insulin to type 2 diabetics. There have also been challenges that have stayed with us. We're still fighting the opioid fight, and I don't know that we're going to end that one anytime soon. There have been new things that have thrown us for a loop. I don't know if any of us were prepared for all the challenges and questions that came up during COVID-19, and there have been many, many, many more things that have changed in medicine. So got to keep your eyes open or you'll miss it and you'll be out of date. One thing I do want to say, though, that has stayed the same, and this kind of harkens to a more recent experience I had after my unit and I completed some field training near Larissa, Greece. We were actually able to go into the city for a couple of hours before we headed back to Italy. And we actually were able to go to the tomb of Hippocrates. That's me and my medical team from the 173rd. And we talked briefly with all of our medics just about the lessons from the Hippocratic Oath, who still hold to this day. So talking a little bit more about the Army. Why did I join the Army, and why is there a B-1 bomber in the right upper corner of this slide? So I grew up in Abilene, Texas, and if you grow up near there, there's a large Air Force base that houses about half of the country's B-1 bombers. And so you grow up under the shadow of these things, seeing them fly over. So the military always was revered, respected. And after I finished up my residency, I did kind of want to do, be a part of something bigger than myself and serve the American warfighter. And when I discovered that it was actually an Air Force recruiter who emailed me and asked me if I was interested in the military, and that Air Force recruiter then kind of talked me into joining the Army later down the road. But truly has been an incredible experience. And here, my father-in-law was actually able to commission me. He's a retired Army officer. So what does internal medicine in the Army look like? I think the big takeaway from this slide is that there is really no typical day. Folks at Walter Reed might recognize the picture there on the left. That's actually from the General Internal Medicine Clinic over by either Delta or Echo. That dog that's there in the picture is Sully, who was George H.W. Bush's dog before he passed away. And now Sully is a service dog at Walter Reed. My time there was probably the closest you can get to what you would consider a traditional internal medicine practice. I was in a large clinic setting where we took care of soldiers, sailors, airmen, and Marines, as well as their families and veterans and retirees. And given that broad spectrum, we saw the gambit of what you would expect in an internal medicine clinic, from your cardiovascular disease, your end-stage renal disease, all of your extremely rare zebra diagnoses and cancers, to all of the common pathology that Dr. Cox kind of referenced earlier. Working your way across the slide, that middle pick was actually taken about a year ago at a brigade-wide training exercise that was done up in Grafenwehr, Germany. That was on one of the last nights where we were actually providing medical care during a notional brigade-wide combat exercise to casualties that come in. And that was all under blackout conditions, under night vision goggles. And then on the far right, that's me and a couple of my current colleagues from our company. And it looks like we're getting ready to fall out of a perfectly good airplane, which I'll talk a little bit more about in a moment. So operational medicine is primarily what I describe doing in the Army. Some synonyms that you guys will hear for it is GMO, or General Medical Officer, or Battalion Surgeon. And now what this means is my full-time job is being assigned to a military maneuver unit. Currently, it's an infantry brigade, but this could be anywhere from the infantry, it could be the armor, the tanks, it could be a combat aviation brigade, so on and so forth. But your job is to be the doctor for that unit, and also the subject matter expert for anything and everything medical, who directly advises that command team. There are additional higher echelon jobs in operational medicine at a brigade level all the way up to combatant command levels. Who can serve in these roles? Pretty much anyone with a generalist skill set. I can say they're not going to put a lot of surgeons into these billets because they need the surgeons in operating rooms doing surgical things. But I've had colleagues in GMO type billets who have been from internal medicine, family medicine, pediatrics, a handful of medicine subspecialists. But if you have a generalist background and you want to do this, you'll be able to do it in the Army. I can tell you it's always in demand. Like when I signaled that this is what I wanted to do, it wasn't hard to find job offers. Will you deploy if you're in operational medicine? Short answer is probably yes. The op tempo in the Middle East has certainly slowed down a bit over the past couple of years, but within our mechanized units, those guys are still spending a lot of time in Eastern Europe, Kuwait, Korea, so on and so forth. That is one of the bittersweet parts of being in operational medicine, is you will have to spend time away from home. You'll do a lot of traveling. As you can see, I think when I totaled it up, I've been to 8 different training sites in the United States, including JRTC and NTC, which those are those, 3 to 4 week long brigade wide exercises where a gigantic military unit moves out into a training area and then they do war games against a notional enemy. And then I've had about a dozen different trainings throughout Europe, one down in Africa, and then a couple of overseas tours in Korea and Afghanistan. Things you'll do: you'll continue taking care of soldiers. Medicine is medicine. It doesn't matter if it's in a clinic at Walter Reed or somewhere in the middle of Fort Polk, Louisiana, or in southern Afghanistan. You have to be confident and competent in providing medical care to your guys. Going through kind of some of these pictures here, that's my medical team from 187 at JRTC. And those 5 officers, we then went to Afghanistan a couple of months after that picture was taken. You'll also be the special staff officer to the command, one of the few people in the unit that can actually go directly to the commander with a concern. And they expect you to give them the best medical advice on what's best for the unit, what's best for the soldiers. You'll do a lot of field training, and you will be expected to be proficient at soldier tasks. A couple of these other pictures, the lower left, that's actually me medical coverage at the Lake Garda water jump that our unit did 2 years ago. We actually dropped several hundred paratroopers into a glacial lake. The one next to that is me and actually our partnered forces, NATO allies, the Dutch army. We did an air assault onto a Greek island. And then the two on the right, that looks like a walking blood bank iteration, and then doing a night shoot with my unit that was in Slovenia. So I do airborne operations in the 173rd. We are an airborne brigade. For people that are on the net who are thinking, I don't really want to do airborne things and fall out of airplanes, I would say that makes you a totally rational, normal human being. You have to volunteer for airborne duty. So this is not something that you can ever be compelled have to do. But for folks who want to do it, you can volunteer to be in an airborne unit. You do get hazard duty pay. It's an extra $150 a month. They send you to jump school at Fort Benning, Georgia. And then once you're assigned to the unit, we jump about monthly. I'll also comment there's a cool medical aspect to this because we actually have to do drop zone medicine. There's a whole litany of injury patterns that we see on the drop zone associated with throwing paratroopers out of high performance military aircraft. But got to pick up the pace a little bit, because I've only got a couple minutes left. Here we go. If you're in an operational unit, high likelihood that you're going to end up having to deploy. I did way back in 2020. Y'all probably remember that was a strange time to be alive. It was an even stranger time to be deployed to southern Afghanistan with the pandemic. But medical did get a little bit of a unique role during that year because we had to advise the command on COVID mitigation while also orchestrating the U.S. and coalition retrograde, while also being poised to provide trauma care because it was a combat zone. And I mean, it was certainly a unique opportunity, some unique challenges that came along with it, but glad to have had that chance to be over there. So we did have to do some trauma medicine. And that, of course, is going to beckon the question, wait, how can an internist do trauma medicine? I thought the internal medicine response to trauma was to kind of curl up into the fetal position. The answer to that is in the Army, you do get pretty extensive training on trauma through TCMC, which is a 1-week crash course you'll get before any deployment, ATLS, ALS, PALS, and then the TC3 and JTS guidelines. And most of the field training that we do is geared towards trauma. Does that mean that you're going to be comfortable in a trauma setting? No. But, for anyone who's been a part of a code blue, like they'll tell you, you're not comfortable at your first code blue, but you will feel trained. You will feel supported, and you'll be able to do it. Clinical medicine is still there every step of the way. Just by eyeballing it, I'm still seeing 2,000 to 3,000 appointments a year, and that comes out to over a decade, 20 to 30,000 patients. At your large DHA MTFs, the big hospitals, you're going to see everything across the spectrum. And then in your active duty soldiers, it's a little bit of a different flavor. There's more musculoskeletal, there's more STDs. And then there are still going to be those rare things that pop up. In the past year alone, we actually did have a bacteremic soldier due to an endovascular graft infection. And we also had a new diagnosis of multiple sclerosis within the past year. And then I think this is one of, if not last slide I've got. So about the medics, if you want to do operational medicine, the single most important thing in a BCT is these guys. It's not you. It's about how well you can contribute to the training of your 68 Whiskeys, the combat medics. These are 18 to 25-year-old guys, typically trained up to the proficiency of an EMT or beyond, but they are the ones who are going to be responsible for the first line trauma care in a real world wartime scenario. And they're going to make the difference whether or not soldiers live or die on the battleground. If the soldier gets to your level of care, they're probably going to live. But whether or not they get to you is completely dependent on all these guys. But maybe the most rewarding thing I've had throughout my career is being able to spend time with medics. Really proud to say that quite a few of them have actually gone on to other professional schools, both in and out of medicine. In the lower right there alone, there are 2 medics at the time who have gone on to medical school, 2 others who have gone to flight medic school, and then another one who is now a pilot. So incredible group of young soldiers that you can have a positive impact on and mentor. And I think with that, the final thought that I'm going to leave you guys with is, if you are questioning whether or not you want to be a part of operational medicine, this picture was taken down at the Global War on Terror Memorial at Fort Benning, Georgia. And this is the reason to be in operational medicine, because over the past 20 years, 25 years, there are guys who have put their lives on the line, and we as Army medicine, we owe them the best medicine can offer and the best chances to come back. And that's why we do what we do.
Dr. Massey, thank you so much. That was an excellent, we hit clinical research really hard, and then it's like, okay, what can you do in internal medicine? And so I think you nailed it by giving us that other end of the spectrum. So with that, thank you, Dr. Massey. And I'd like to introduce us to, you had awesome photos and your lovely family.
Thanks, Al.
Thanks, Dr. Massey. So our next speaker for internal medicine, aerospace medicine, as you can see from the slide, I had to Google a handful of these acronyms to see exactly all the things he has done in his career. So retired Colonel Dean Winslow from the Air Force is going to talk to us a little bit about his kind of leadership and pearls in past and walk us through lessons learned over the years. So welcome, Dr. Winslow. Thanks, sir.
Great. Austin, thank you so much for inviting me to participate in this. And again, it was wonderful hearing the two previous presentations. So just a little bit of a caveat, I didn't put any slides together about my own kind of journey, but I actually graduated from medical school in 1976, so almost 50 years ago. I was only 23 years old, and I was in this special accelerated program. I loved aviation, though, since I was a little kid. In fact, got my student pilot's license when I was 14 years old. My dad served in the Army in World War II. My grandfather served in the Army in World War I. And so serving in the military was something I always wanted. I just loved biology and always wanted to be a doctor as well from the time I was a little kid. So, when I learned a little bit about Air Force medicine and particularly becoming a flight surgeon, that was like totally a dream come true for me. So again, when I was in medical school in the early to mid 1970s, and in residency in the mid to late 1970s, the Vietnam War had just wound down. And the active duty military was like dramatically downsizing, and particularly, the medical corps, so the Army, the Navy, and the Air Force. So when I went to talk to the Air Force recruiter to basically go on active duty or to volunteer to go on active duty in the mid 1970s, he actually steered me to the Air National Guard. He said, honestly, Dr. Winslow, we're at the point where we're downsizing. We really don't need a lot of people in the active duty military, but we know we're going to have more wars in the future, and the Guard and the Reserve are going to have to be playing a big role. So anyway, I ended up finishing my medicine residency in Delaware, and then did my infectious disease fellowship down in New Orleans. But I was commissioned in 1980, went to flight surgeon school. My fellowship program actually gave me 8 weeks off for the training, and plus 4 weeks for survival school. And so basically weekends and, 2 weeks a year for the first few years, I just absolutely had a wonderful time. My first unit that I was assigned to was a Louisiana Air National Guard. And you can see on the photograph on the left, that's a F-4 Phantom jet, which was the main, dual role fighter during the Vietnam War. So again, this photo was taken probably 1982 or 83. Almost all of the guys that I flew with then, had flown combat in Vietnam. In fact, several of them had actually flown with Brigadier General, and the time Colonel Robin Olds, who was considered kind of the iconic fighter pilot, really, of the Vietnam War. It was just an absolute, blast to be part of that wonderful community. Things got really serious, though, beginning really in 1991 when we did the initial invasion of Iraq. And then, of course, we ended up basically establishing no-fly zones, both in the Kurdish north as well as in the Shia south after that first Gulf War. I was, of course, ended up, deploying many times, with my unit. One of the things that I love, though, about being an operational flight surgeon, by the way, that was my primary AFSC, was a flight surgeon, sort of like, basically Lieutenant Colonel Massey, his talking about, his primary AFSC is really a battalion surgeon, not an internist. But I think, being an internist, though, and I'll talk about this in a few minutes, was, a wonderful attribute to have, and certainly, increase the ability that I had to contribute to the mission. So again, I want to thank Austin for consolidating a lot of these photos. So again, you look at the photograph on the top left, that actually is me as a tactical scanner in the left aft paratroop door of a combat rescue C-130 during the initial invasion of Iraq in 2003, when I was the flight surgeon responsible for combat rescue operations, basically from the AOR from Tikrit all the way through northern Iraq. Again, the picture on the right, again, is probably following a mission during that time. The lower left picture is the altitude chamber that, as a flight surgeon, that you have to go to at least every 3 or 4 years, as no matter what your crew position is in the Air Force. The lower right is actually just kind of a little bit taken out of context, but in 2004, during my first deployment to Afghanistan, I was actually asked by U.S. State Department to be the flight surgeon and accompany President Hamid Karzai to go all over Afghanistan to give essentially campaign talks, for the very first free elections. And again, he actually was very scared to leave Kabul because of the fact that every time he did leave the Afghanistan capital, someone tried to kill him. And he told our State Department that the only way that he was going to leave Kabul was if he had a U.S. Air Force flight surgeon assigned to him. So anyway, I had a huge bag of things like chest tubes and IV bags and IV catheters and airways and things like that. So I basically went around with President Karzai for 4 or 5 days as he gave talks all over Afghanistan. And that's my one of my C-130 crews that I was assigned to. Again, my primary assignment that then was as the flight surgeon responsible for all of the flying units at Bagram Airfield, which was our largest airfield in Afghanistan. Next slide. And then one of the other things, by the way, that a flight surgeon does, in addition to caring for the air crew, is of course responsible for assessing patients for suitability for air medical evacuation. You work very closely with air evac people. Again, the upper left picture is just a combat mission that I went on as an additional crew member in Afghanistan in 2004. And you see in the middle there 2 Afghan National Army soldiers, along with some of our security people, as well as some fellow air crew members. The upper right is actually a picture of our flight medicine clinic, not very fancy, at Al Udeid Air Base in 2003. Again, this is shortly after the initial invasion. The lower left is MASSIVE, stands for basically our aeromedical staging facility. And that was initially at Baghdad during the first part of the Iraq War. Then later that we established our major level 3 hospital up at Balad, which is about 40 miles north of Baghdad. And then the lower right is fast forward to 2011 during the surge in Afghanistan. And that's actually what we call a B hut. And these were huts that were actually built out of plywood back in 2002, shortly after we moved into Afghanistan. And I think nobody thought that the war would ever possibly last 10 years. So you can see that the paint has really faded off of our flight medicine clinic. Next slide. And again, this is, as I mentioned, one of the other things that flight surgeons in the Air Force often are tasked with helping supervise or even participating in as crew members is aeromedical evacuation. And again, in tactical aeromedical evacuation often starts out, of course, as CASEVAC, with usually U.S. Army or sometimes combat rescue helicopters, evacuating patients, directly from the front lines, to more forward surgical facilities. But then again, once they're stabilized at a level 2 hospital, like either at Baghdad or again at Kandahar or something like that, then that they're evacuated into a larger facility. So again, this may occur, with a C-130, or if it's actually, taking a patient from a level 3 hospital to typically Germany, that you'll be in a C-17. But again, the air evac crews are the ones that really make this happen. But again, flight surgeons, though, are very important, though, in this whole process. Again, so these are some pictures that Austin put together, just showing some photographs of, what it was like to be forward deployed in Afghanistan. So 2 of the assignments that I'm very proud of participating in was in actually helping run the emergency room at our small Air Force combat hospital at Baghdad International Airport in 2006. And then I returned in 2008 as the commander of the EMEDS. So again, the picture on the upper right is just, some of our wonderful airmen, many of whom I still keep in touch with. And it's hard to believe that that's been like almost 18 years ago. But one of the things that I'd love, the students really just to appreciate is the wonderful thing about serving in the military is that you are on the most wonderful team in the world. Many of you probably played sports in high school or even in college, and you kind of remember that wonderful camaraderie that you had, with your teammates. And what I'd like to tell you, though, is being part of the military is really being part of the very best team in the entire world. And this is something that, you'll look back on your entire life, with a lot of pride and satisfaction. Next slide. Yeah. So again, there's just some scenes from Baghdad. So this is pretty intense stuff. These are my medics taking a wounded soldier off of a medevac helicopter, bringing him to our EMEDS, for life-saving care in 2006. This is what a mass casualty looks like in the real world. Again, our hospital was a relatively small hospital. We only had 4 main trauma bays, 2 surgeons, 1 anesthesiologist, and 2 ER doctors and myself. So it's really all hands on deck, when again, a convoy is hit by an IED and all of a sudden, you have a dozen casualties arrive, in your ED. Often after we would get patients, stabilized actually in the trauma bays, because we only had the 2 surgeons, myself and the other ER doctor and any other physicians there, we would often scrub in to actually serve, actually in the OR. This is actually a kind of a case I'd like to real briefly tell you about. And this is one patient that I remember very clearly from 2006. This is before the surge, when things were really not going well, in our war in Iraq. And this is an intraoperative photograph taken of an insurgent. And again, you can see probably in the right-hand side of the picture a bone saw, and the orthopedic surgeon is actually getting ready to amputate this insurgent's leg. The story behind this is that about 4 days before, a U.S. Army Apache gunship was actually shot down by insurgents about 20 miles south of Baghdad, and it crashed and burned. And the Islamists who shot this helicopter down actually posted a video on their website showing them dragging the pilot and the gunner's body out of the helicopter, and then it was posted on a website. And I think even the people that saw this on the website were kind of offended by just sort of the violence and everything. And so anyway, they essentially, these guys were turned in by their fellow Iraqis. And a U.S. Navy SEAL leading a team of Iraqi Special Forces soldiers actually found this person, identified the compound where this occurred, and there was a firefight that ensued. At one point, they thought the firefight was over, and then the person who was actually the leader of this insurgent cell came around the corner. Everyone was looking the other way. The Navy SEAL saw him out of the corner of his eye, and very quickly reacted, drew his 9mm pistol and shot the insurgent in his right thigh, severing his femoral artery. And the thing that just amazed me was that he told me a few hours later, after this insurgent was brought to our EMEDS in Baghdad, how basically this Navy SEAL, who was primarily a weapons person, but was also trained, essentially as a medic, ran over, jammed a roll of Kerlex in this guy's, wound that was, spitting blood out, and then applied a cat tourniquet to it, and then inserted an IV. And by the time that he got to our facility, he'd received about 2 liters of Ringer's lactate, saving this insurgent's life. And so, I know that there's, a fair amount of anti-Americanism in the world, but I just want all of you to take pride in the fact that, what other country in the world would actually save the life of a person who 2 weeks before, had killed two U.S. Army aviators. So anyway, that was something that just, again, still just really is a very powerful memory. Sadly, we couldn't, of course, save the lives of every person that, we saw, in our trauma facility. And, I still wake up at night, with bad dreams about probably the 250 or so, what we called Patriot details that I participated in, where the following day, that the flag draped transfer cases were loaded by an honor guard onto either a C-130 or a C-17 to start their journey back to Dover. Next slide. One of the things, though, that particularly, as an internist, as well as being, an infectious disease specialist, is that you really can be a huge help, downrange in providing care, particularly to host nation nationals, as well as, of course, our own soldiers. Remember, though, that, again, people that are wounded or who are very ill, and may be hospitalized, let's say at a level 3 hospital, either in Iraq or Afghanistan, usually Americans or coalition forces are medevaced out, within 24 or certainly 48 hours. However, we often ended up caring for host nation nationals. And again, don't quote me or anything, but we were actually, in theory, not supposed to care for host nation nationals, in our facilities. However, we had excess capacity. And so the reality is that almost every single hospital commander sort of broke that rule all the time. And we ended up actually caring for a lot of host nation nationals, in our facilities. And it really didn't hurt us at all. It didn't compromise what we were doing, but it was certainly very satisfying. And these are just some photographs of a couple of children with congenital heart disease that, I was asked to see at a clinic run by the U.S. Army Special Forces outside the wire of our base in Baghdad. A couple of boys with congenital heart disease that I was able to arrange care for to get their heart defects, repaired in the U.S., since there were no cardiac surgeons left in Iraq, after our invasion in 2003. A child with severe burns that I was able to arrange to get care at Boston Shriners Hospital. A little boy with severe scoliosis on the lower left, who was able to arrange care for at, Shriners Hospital in Philadelphia. Next slide. So again, certainly very satisfying. And again, the friends that you make when you're deployed, these are just such intense experiences. And again, the guy on the left there, that's Colonel Dave Pavey, and he's actually going to come and visit us at New Year's. He's, of course, now retired from the Air Force. He's a C-17 pilot, a former C-17 pilot. And again, the friends that you make and are just, it's hard to imagine. Just, how wonderful and close these friendships remain, even 20 years, after you served with them. Next slide. Again, this is again a photograph probably from 2008 or 2009. Several of the Iraqi children and their mothers, who I was able to bring over with their kids, obviously, to have surgery in the States. Next slide. One of the other things just I'd like to just briefly talk about, just as an internist, as well as being a flight surgeon, that since that was my secondary AFSC, actually, was being an internal medicine and an infectious disease specialist, I was actually asked by the U.S. Army when I was deployed to Afghanistan in 2011 to help them develop criteria and policies and procedures for screening and treating detainees in Afghanistan for tuberculosis. And one of the things that many people may not realize, though, is Afghanistan actually has a lot of TB, and our defense, our DFIP, which was the main facility, basically, where we incarcerated Afghan insurgents, which was on the northeast side of the airfield at Bagram, had at one point almost 3,500, I think, people that were basically incarcerated. And so, I was actually consulted by the commander of the Craig Joint Theater Hospital to actually help them develop policies and procedures for screening the detainees for tuberculosis. The upper right is actually a photograph that I took of the ziggurat of Ur. Many of you probably remember that Babylon was the old name for what is now Iraq. And when I was deployed, as flight surgeon supporting our combat operations during my second deployment in Iraq in the summer and fall of 03, I actually requested of my operational commander if I could get permission to actually spend 3 or 4 days at Talil Air Base in southern Iraq, because I knew that there was a huge outbreak of leishmaniasis in American soldiers and Marines that were in southern Iraq. And so actually I got to see many cases of cutaneous leishmaniasis. It just turned out that coincidentally, that the person who was in charge of the Theater Army Medical Lab was also one of the world's experts in leishmaniasis. So it was really almost like a continuation of fellowship for me to be able to spend those 4 days at Talil. And again, the lower right is actually, again, another photograph actually of our a detention facility in Parwan, where again, I was able to help because of my internal medicine and infectious disease background. The Army developed, state-of-the-art screening and treating procedures, for tuberculosis. The upper left is actually just a file photo. I didn't take that, but that is actually the facility in Baghdad where prisoners were held. And this was called Camp Cropper. And this was opened up actually as they closed down the notorious prison at Abu Ghraib, where the abuses had occurred. But again, I actually went out to our Camp Cropper at least twice a week and did consults on detainees that had infectious disease issues. So again, I think we made a real difference. And even though many of us feel a lot of sadness about the way things happened, both in Iraq and Afghanistan, I think there's probably thousands and thousands of people that are grateful for the good that we did while we were there. Next slide. And again, some of the other kind of fun things that I was able to do as a flight surgeon and a doctor in the Air Force was I served for 6 weeks as the flight surgeon deployed to McMurdo Station, Antarctica. And many of you know that the U.S. Air Force flies the C-17s that are based out of Christchurch, the South Island of New Zealand, and fly to McMurdo and land on the ice runway. And in addition, we usually deploy from the New York Air National Guard 3 or 4 C-130s on skis every year to McMurdo. And then those are the aircraft that actually deliver cargo to the actual South Pole and several of the other stations. And they land on skis on ice runways. And so, again, just an amazing experience. So just trying to, you'll get great experiences in the Army, but some of the stuff that we get to do in the Air Force is really very special. In 2005, I think many of you know that Hurricane Katrina hit. The seawalls, again, were overwhelmed. New Orleans and surrounding areas were flooded. And it was a huge disaster, and with literally, hundreds of thousands of people were displaced from their homes. And I was asked by the National Guard to actually lead up essentially the public health and force protection for, at that point, 50,000 guardsmen who deployed from all over the country, to New Orleans and Louisiana for the relief. This is actually just a photograph that I took from a U.S. Army Black Hawk looking down on a Coast Guard helicopter as we're rescuing people, from flooded buildings in New Orleans. And then I retired officially from the Air Force and the Air National Guard in early 2016. But then I think many of you remember that COVID happened, and I was actually asked by the CDC to lead COVID testing for the U.S. government. And I, immediately, said yes, to this offer. But the CDC told me that, well, we're going to be honest, though, with you, Dr. Winslow, that it's going to be probably at least 4 or 5 months because of the bureaucracy in the federal government that we could hire you as a civil service employee. And I wonder if there's any chance that you could go back on active duty. So at age 67, the California National Guard put me on Title 32 orders, and I deployed to Washington, D.C. to lead COVID testing for the U.S. government. That's a picture with Tony Fauci, and then the person on the far left is Cliff Lane, his associate. So again, I was, I think at one point, probably the oldest officer on active duty in the United States. And then finally, I guess in the later in the year that I went back to being a civil service employee. So just I'm going to close with just a couple of little pictures about some of the other things that I did while I was working for the CDC. So I think all of you remember is 2021 when Afghanistan fell to the Taliban. Sadly, really within weeks of us pulling our forces, out of that country. And I think many of you remember these, horrific scenes of terrified Afghans, most of whom, had worked with coalition forces and just fleeing for their lives, because of the threat of death from the Taliban. And I think for all of us, who served in Afghanistan, that these pictures were very traumatic and really triggered a lot. This, by the way, is a photograph taken from up near the cockpit of a C-17, looking down in the cargo compartment. And this actually shows a C-17 at Kabul, probably just before it took off, with 934 Afghan civilians, which absolutely has to be a record for the number of people that have been ever placed in a C-17 aircraft. I felt in a way very grateful that since I was in charge of COVID-19 testing and had some other responsibilities, I was very quickly asked to serve as Senior Centers for Disease Control, or CDC advisor, for what we called Operation Allies Welcome, which was the resettlement of these 124,000 Afghans that arrived over a period of 3 or 4 weeks in August and September of 2021. And this is a photograph that I took of the very first Afghan refugees arriving at Dulles International Airport near Washington, D.C. So again, it was, I think, very healing for many of us to be able to, help these very deserving people that put their lives at risk, to work with coalition forces. And I think the last couple of slides, basically, this is a photograph that I took at Fort Bliss. So one of the other jobs that I had was serving as the senior CDC advisor for the resettlement of the unaccompanied children at the southwest border during late 2021 and early 2022. Again, there's a lot of politics involved with this right now. And again, just as somebody who, is a father, a grandfather, and a Christian, I was just heartbroken. And so I was very proud of the fact that I think we made a real difference. During the Biden administration, we actually did weren't welcoming folks, but we were actually, if they got over the border, that we made sure that they were treated humanely. And so again, these unaccompanied children, most of whom came from Guatemala, second most common came from Honduras, came across the border. We made sure that, we got them, cared for properly at Customs and Border Protection sector stations, and then usually within 24 hours transported to a HHS-run emergency intake site. And again, very, very proud of both the kindness and the care that was given by both Department of Homeland Security and HHS in the care of these children. And again, it was a real honor to be part of this operation as well.